Assalamu alaikum. I am Dr. A. Muhammad Fattouh, Professor of Pediatrics and Pediatric Cardiology, Cairo University. Today we are going to talk about pediatric cardiac catheterization. Our main objectives in this lecture will be to define cardiac catheterization, what are the indications to refer a child to the cardiac cath lab. We will have an overview about the different procedures. We will not go into deep details. What are the possible complications that we might encounter during or after the procedure? First of all, cardiac catheterization involves the evaluation and manipulation of the heart and surrounding vessels through catheters placed in peripheral vessels. يعني بمعنى آخر إن إحنا we are introducing catheters inside the vessels reaching to the heart. Diagnosis of congenital heart is done by several ways. The most basic and important evaluation depends on the clinical examination. Basically the chest X-ray, ECG, echocardiography, and then we proceed to the more invasive procedure used for diagnosis, which is the cardiac catheterization. There are other modalities used nowadays, and certainly these modalities have limited the use of cardiac catheterization in diagnosis, such as transesophageal echo, magnetic resonance imaging for cardiac magnetic resonance imaging, CT, and so on. So now cardiac catheterization in children more and more used for therapeutic reasons. But still the role of diagnostic cardiac cath cannot be undermined in difficult cases where it is still the gold standard. What are the possible therapeutic procedures? We might use devices to close septal defects, to close PDA. We might use balloons to dilate stenotic lesions or the stenotic valves. We might use stents for vascular stenosis. We might close vessels using embolization and devices. And now there is growing use of the percutaneous pulmonary valve implantation. So the indications for cardiac cath, or to refer a child to the cardiac cath, either diagnostic or therapeutic. Diagnostic cardiac catheterization can provide enormous information. We can use angiography, inject dye, ionizing dyes in the ventricle or the vessel, and using the fluoroscopic imaging, we have a more detailed information about the anatomy of the lesion. We can measure the pressure invasively. You are measuring the pressure inside the ventricle using the catheter or inside the pulmonary artery. So this is direct measurement, not just estimation like we use in echocardiography. We can get samples from the different chambers or different blood vessels and measure the oxygen saturation in these blood samples. Through all these measurements, we can calculate the cardiac output and the pulmonary vascular resistance. These data can lead us to take an accurate decision regarding the surgery that could be done for this child with congenital heart disease. How we are measuring the pressure? It is direct measurement. The catheter is inside the heart or inside the pulmonary artery, is connected to a closed circuit. So the catheter is coming out through a trivalve. This trivalve is connected to a fluid-filled pressure there is a transducer here that transmits the pressure in the catheter, which is placed inside the heart or the pulmonary artery, for example. And through this transducer, this pressure is transmitted to this fluid-filled catheter. And this fluid-filled catheter, and through this transducer, there is a cable or connector to the hemodynamic machine in the cath machine that translates these pressure changes into waves that could be read and interpreted. There are normal intracardiac pressures with normal ranges. For example, in the right atrium, it is supposed to be between 0 to 6 millimeter mercury, in the right ventricle between 15 to 30, the left ventricle between 100 to 140, and so on. The pulmonary artery between 15 to 30. Okay. In each chamber of the heart, blood can be aspirated through a catheter. We have talked about pressure measurement. The other data that we can obtain are the oxygen saturation in the different chamber, which can be obtained through blood samples drained from the specific chamber that I want to know its oxygen saturation. These data are used to calculate the pulmonary blood flow, the ratio of the pulmonary blood flow to the systemic blood flow, which is called QP-QS ratio. What does it mean? In the normal situation, the two circulations, the pulmonary and the systemic, the ratio between them is supposed to be 1 to 1, as there is no shunt between pulmonary and systemic circulation. What if there is a shunt in the form of ASG or VSD or PDA? So the blood will flow from the left side, which is the higher pressure, to the right side. This means that the blood will go more to the right side, which is the pulmonary circulation, which means there will be increased pulmonary blood flow. So, in the presence of left to right shunt, the pulmonary circulation will be higher or more rapid than the systemic circulation. If this shunt is small, so the ratio will be between 1 to 1.5. If it is more, it will be between 1.5 to 2, and it will be intermediate. But if it is more than 2, this means there is a large left to right shunt. What if the patient became hypertensive, or what we are calling Eisenmenger? So there will be a right to left shunt because the pressure in the right side has been increased more than the left side. And in this case, the ratio between the QP-QS will be less than 1 because the blood in this case will go from the right side to the left side. So, what are the indications to send the child with congenital heart disease for diagnostic cardiac catheterization? The indications are classified into class 1 with the level of evidence A. These category are those who are undergoing planned interventional cardiac catheterization, and we are doing hemodynamic and anatomic, and we are obtaining hemodynamic and anatomic data prior to the procedure. For example, if I am going to close a PDA, I have to do an angiography to delineate the shape and size site of this PDA, which will help me to decide the size and the type of the device used for closure. If I am going to close a VSD, I have to do LV injection to accurately define the position of the VSD and use it as a reference or a roadmap in front of my eyes on the fluoro while I am doing my procedure. It is also recommended to do cardiac catheterization to assess the pulmonary vascular resistance and reversibility of pulmonary hypertension in patients with congenital heart disease or primary pulmonary hypertension when accurate assessment of pulmonary resistance is needed to make surgical and medical decisions. For example, I have a child 6 years old, large VSD. This VSD was neglected. The patient has resting oxygen saturation on room air about 90s. So I have a doubt if this child is still operable and his pulmonary vascular resistance is responsive or not. So this child must undergo cardiac catheterization. Accordingly, I will calculate the QPQS. I will calculate the pulmonary vascular resistance index and decide if this child is still operable and he can do complete repair with closure of his VSD or he is not. Favorable outcomes are expected if I have a baseline QPQS, on room air, 1.5 to 2, or the pulmonary vascular resistance is less than 6 Woods unit, or the ratio between the pulmonary vascular resistance and systemic vascular resistance less than 0.3, or the age is less than 1 year. What if we did the calculations on room air and the pulmonary vascular resistance to systemic vascular resistance was more than 0.3? This means that this child has a pulmonary vascular disease. So I will give him 100% oxygen. Why? Because oxygen is a vasodilator, pulmonary vasodilator. So I will give him oxygen for 10 minutes, waiting for its effect to dilate the pulmonary vessels and redo my calculations and my samples and my pressures again. If this ratio drops to below 0.3, this means that this child is still responsive and I can send him for surgery. This, for example, a child with ESD or interatrial communication. So the blood will flow from the left atrium to the right atrium. This means there is increased flow to the right ventricle and accordingly to the pulmonary artery. And if we do our calculations, we will find that QPQS will reach to 3. Other indications, cardiac cath can be used in complex pulmonary atresia to see the lung segmental pulmonary vascular supply. I want to know each lung segment supplied by which blood vessel to see if this child is to delineate which surgery can be done for this child. Also, you can use it for coronary circulation in pulmonary atresia with intact septum. Cardiac catheterization is also indicated in cases for patients who is going to undergo cardiac transplantation to have a cardiac biopsy in case of graft vasculopathy after cardiac transplantation. But actually in Egypt, as we don't have a cardiac transplantation program, we might need to do a cardiac catheterization for those patients with complex lesion in which we couldn't reach a final or complete diagnosis using the non-invasive tests. We might need diagnostic cath for the coronary circulation in cases of Kawasaki or to assess the anatomy hemodynamics in post-operative cardiac patients when the early post-operative course is unexpectedly complicated. This was an overview about the indications for diagnostic cardiac catheterization and what are the data we are planning to obtain by doing this invasive procedure. What about interventional cardiac catheterization? The role of cardiac catheterization in interventions for congenital heart disease are now rapidly progressing. Simply, if you imagine that 20 years ago, half of the cases coming to the cath lab, or more than half of them, were coming for diagnostic cardiac catheterization and the other half for intervention. Now, the cases for intervention are almost 70% or 80% of the cases undergoing catheterization, and only 20% are diagnostic cardiac catheterization. What are the different procedures that we might use for intervention in the cardiac cath? The oldest or the first one was atrial septostomy, which is named after Dr. Rashkin. Its idea was to enhance the atrial mixing, especially in cases of transposition of the great vessels. Those patients have parallel circulation, parallel pulmonary and systemic circulation, and the only way to live for them is by mixing, especially at the atrial level. Of course, they have a PFO, but sometimes this PFO is restricted, and there is very little mixing across it. So by using this technique, we introduce the Rashkin balloon filled with the dye, and we pull it through the PFO. It will rupture the rims of the PFO to increase the interatrial communication and hence enhancing the mixing. Balloon atrial septostomy is effective in treatment in infants less than 6 weeks. But if the child is 1 or 2 months old, it will be difficult as the septum becomes thicker, and it will be difficult to enhance or to widen this opening. The generally agreed indications for balloon atrial septostomy is TGA with or without associated cardiac defects, and cases with tricuspid atresia with restrictive ESD. Now you see this is guided by echo. The balloon is inflated and then we pull it so the PFO becomes more bigger. Other indications for atrial septostomy in cases of hypertensive pulmonary or systemic venous chambers with restrictive atrial communication. Sometimes we need to increase the atrial the size of the atrial communication prior to surgery. Transseptal puncture and static balloon dilatation in cases we need to decompress the left atrium. Sometimes in cases of pulmonary arterial hypertension, those patients who have primary pulmonary hypertension or pulmonary hypertension due to other untreatable causes, so they need to decompress the right side and create some sort of vent between the right atrium and the left atrium. Of course, the baby will or the child will become more blue, but this will decompress the high pressure present on the right side. Sometimes we enlarge the existing defects, and most of the times we want to close these defects. So cardiac catheterization can be used to close ASD secondum. In patients with hemodynamically significant ASD with suitable anatomic features. What do we mean by suitable anatomic features? We mean that there is a preferable size of the rims of this ASD. The ASD is a hole which has rims all over. The device we are using is supposed to be hanging on these rims. If one of these rims is not sufficient or its size is less than what we need to hang this device, so it's not suitable. Patients with transient right to left shunt across interatrial communication. For example, those patients with the PFO, although the PFO is a small hole and it doesn't confer any hemodynamic significance, yet sometimes there is right to left shunt across this PFO. And in very minor percentage of patients, they might undergo paradoxical emboli leading to stroke or recurrent transient ischemic attacks, and in this case, closure of PFO is indicated. What's the idea? The idea is that we are loading the device used for ASD closure on a cable, introduce it through a delivery system which crosses through the defect. Then we return back with the sheath to open the first disc. The device has two discs. We open the first one, then we release the other disc, and then we unlock the cable and leave the device here. As you see, the defect is now sandwiching the rims of the defect. These are the rims which we are supposed to evaluate before we do device closure for the ESD second. We do this procedure guided by transesophageal echo and sometimes by transthoracic. We can find this is the right atrium, this is the left atrium, and here's the defect. And these are the rims which we are supposed to evaluate prior to closure. Then this is after releasing the device. The device is in place. Within 6 months, there is complete endothelialization over this device. Not all ESG defects are indicated for closure. For example, those small defects with minor shunt or single defect that's too large for occlusion, the size is 38 millimeter, for example. You cannot put such huge device in a child because he might undergo a heart block or arrhythmias due to presence of this device. Multiple ASDs unsuitable for percutaneous closure. Defect too close to the superior vena cava or IVC or pulmonary veins. If the rings are less than 5 millimeter, but this is somewhat debatable or controversial. Abnormal pulmonary venous drainage, because in this case you will refer the patient for surgery. Associated congenital anomalies that will require cardiac surgery. Severe pulmonary hypertension or bidirectional flow. Presence of intracardiac thrombi diagnosed by echo. What about the VSD? Closure of VSD by cath is now growing, and by the availability of many devices, we can now close many types of VSDs, but still there are types that are not indicated for closure by cath. For example, those with malaligned VSDs, which means that the rims of the defect are not at the same level. For example, inlet type VSDs, those are not indicated for closure by the cardiac cath. Again, if there is other associated cardiac defects that necessitate surgery, if it is a huge defect, all these conditions are contraindications to try to close by cardiac cath. Infants who weigh more than 5 kilograms, children and adolescents with hemodynamically significant, which means there is left ventricular or left atrial volume overload, or there is significant shunt with QPQS more than 2, can undergo percutaneous VSD device closure after making sure that the morphology, the size, and the location of the VSD are suitable for closure. For example, if we have a defect very close to the aortic valve, we cannot close it by the device because we might endanger this aortic valve. In infants who weigh less than 5 kilograms, and children with hemodynamically significant defects who require a cardiopulmonary bypass, we can perform hybrid perventricular closure of the VSD off bypass, followed by surgical repair of the remaining defects. The surgeon do sternotomy and right ventriculotomy, and we deliver the device through this RV opening. Now there are different types of devices that we can use for closure of the VSD, and we decide which type of the device to use according to the shape, size, proximity to the nearby structures like the aortic valve or the tricuspid valve. These all factors determine which type to use for closure. For example, this is a device which is primarily used for closure of the PDA. It's called EDO1, but we can use it for closure of the VSD. This is another device originally designed for the PDA, but we can use it also for the PDA. This is what's called BFM coil, but it is designed specifically for the VSD. This is the muscular device. So there are a variety of shapes and types that we can use for closure of the VSD. Another indication for interventional cardiac catheterization is closure of the PDA. This small vessel that is supposed to close immediately after birth, sometimes it remains open and necessitates closure, especially in those with moderate size or large PDA causing considerable left-to-right shunt, which leads to congestive heart failure, failure to thrive, pulmonary overcirculation, or enlarged left atrium or left ventricle. In this case, we introduce our catheters and our delivery sheath with one of the coils or devices used for closure of PDA. Other conditions such as audible PDA with small left to right shunt or normal sized heart chambers, we can close these PDAs also. Again, large PDAs with pulmonary hypertension and bidirectional flow might be closed in the cath lab, but it's more safe to be closed by surgery. There is a huge debate around closure of silent PDAs. There are some with the opinion of close and others who said no need to close, but in our cath lab we adopt the theory that if you can cross it, close it. Now, after we had an overview around the defects to be closed, we will go through other types of interventions, which are the balloon dilatation. Balloon dilatation can be used to dilate stenotic valves or stenotic vessels. The most commonly used ones are a pulmonary valvuloplasty, depending on the fact that pulmonary stenosis is one of the most common congenital heart diseases. There are different grades of pulmonary stenosis. The most severe of them is what's called critical valvular pulmonary stenosis, which is pulmonary stenosis present at birth causing cyanosis due to right to left shunt across the PFO. And in some cases, those infants are somehow duct dependent because the flow across the pulmonary is so much reduced. The less severe degree is the valvulopulmonary stenosis with peak pressure gradient more than 50 millimeter mercury, or peak instantaneous gradient of more than 40 millimeter, or clinically significant valvular obstruction in the presence of RV dysfunctions. All those are indications, frank indications for balloon valvuloplasty. We can also try to dilate pulmonary valve which is dysplastic, although we know that the prognosis of the dysplastic pulmonary valve is not favorable, which means that we might need to dilate it several times, and at the end we might need to do surgery. But we can try to palliate the child first with balloon dilatation. What do we do in balloon valvuloplasty? First, we do the angiogram to delineate the size and to have a landmark for positioning of the balloon. Then we after we introduce the catheter, and then the wire, and then the balloon is introduced over a wire and inflated, so the waist, which means that the commissures of the stenotic valve becomes torn, and we dilate the stenotic valve. There is a category of pulmonary atresia, intact septum, in which we can do what's called radiofrequency ablation. Radiofrequency ablation depends on making a hole through a membranous pulmonary atresia. The guide wire we use, after making a hole, we introduce the wire and then the balloon and do balloon valvuloplasty. Less commonly is the aortic stenosis, in which we might need to do aortic valvuloplasty. It is indicated regardless of valve gradient in newborn with isolated critical valvular aortic stenosis. Sometimes those infants are duct dependent, or in children, older children who have isolated valvular aortic stenosis with depressed left ventricular systolic function. So we do balloon dilatation to relieve this obstruction. Aortic valvuloplasty is indicated in children with isolated aortic stenosis with peak systolic valve gradient more than 50. We introduce the balloon over a wire and crossing the aortic valve and do the inflation. Here you can see the sides of the valve causing this waist of the balloon. Our target is to inflate the balloon to alleviate this waist. Coarctation and recoarctation. Dilatation of aortic coarctation by the balloon is indicated in cases of gradient more than 20, and it is indicated primarily in cases of free coarctation after surgery and not in primary coarctation. But sometimes, here you can see the balloon across the stenotic segment of the aorta, and this is after inflation. Sometimes we to dilate to try to dilate a native coarctation in cases with depressed ventricular function, and the child cannot be transferred for surgery. So we try to decrease the obstruction somehow to allow the ventricular function to get better and be able to be referred for surgery. Another category of intervention is the stent, and one of the most urgent and critical conditions are PDA stent. The aim of PDA stent is to maintain ductal patency through percutaneous implantation of balloon expandable stents. It is an attractive alternative to the conventional surgery to do a BT shunt in patients with duct-dependent pulmonary circulation. Duct-dependent circulation is a critical group of congenital heart in which the life of the patient is completely dependent on maintaining the circulation through the PDA, either pulmonary circulation or systemic circulation. So we use coronary stents which have better profile, flexibility, and trackability to stent the PDA and maintain it open until the patient can be referred for surgery. It is reasonable to stent an anatomically suitable ductus in an infant with cyanotic congenital heart who has more than one source of pulmonary blood flow. For example, antegrade pulmonary blood flow, but requires additional blood flow, which means those with critical PS who we cannot dilate. It's also reasonable to try to stent the PDA if it is the only source of pulmonary blood flow. First, we do angiography to delineate the ductus and use it as a map to insert our stent. Then, after introducing a coronary wire through the PDA, the stent is progressed over the PDA and over the wire and then inflated. The balloon, we go out with the balloon and leave the stent inside the PDA. We do another angio, and here we see the flow across the PDA stent. What we do before cath? Cardiac catheterization needs preparation of the patient. We cannot just tell the patient that you need cath, then go to the cath lab. No. We need detailed clinical evaluation before the cath on the day of the cath, because it is an invasive procedure, and you should plan ahead what you are going to do. Even if you are doing a diagnostic study, you should have a clear plan what are the data you are searching for, and what you are planning to do inside the cath lab. So clinical evaluation is the basic step before even taking the decision to send the patient to the cath lab. Revise all his previous procedures. What are the types of operations done? What if there is a previous cath done to the patient, previous CT or MRI, TEE, his echo reports, everything he had before must be evaluated thoroughly. Reports about previous operations, previous admissions, all these data are very, very important. You should perform echo before admitting to the cath room. Revise his basic ECG, his chest X-ray, to know if he has any underlying problem with his rhythm, any types of arrhythmias. Laboratory evaluation. The patient should have a CBC, a recent CBC, coagulation profile. Sometimes we need the CRP or C-reactive protein. For example, if the patient was admitted before coming to the cath lab, to make sure he is free of infection by revising his CBC and CRP. Sometimes if the patient, especially if the patient has previous operation, we might ask for liver function and the hepatitis markers. You should revise all the equipments that you might need inside the cath lab. Revise that you have all the catheters that you might use, all the types of wires that you might need. If you are going to close or dilate or using a stent, you should revise that you have all these equipments beside you. If you are going to do an interventional procedure, you should have blood reserved just in case there is blood loss that necessitates blood transfusion. What about after the procedure? Monitoring is by far very important. The patient is delivered to the ICU, accompanied by his doctor or his anesthesiologist and a nurse to be monitored in the post-cath ICU, proper transportation, proper observation of his vital signs to make sure that his pulses regained well. If there is any drugs needed to be given, for example, those who underwent ASD or VSD closure will need heparin for 24 hours to make sure that there is no thrombi over the device, and they should continue as proceed for at least 6 months. Again, for those underwent PDA stent, we will need the heparin to make sure that the stent remains without thrombosis, and plan for the follow-up for the patient later on. What are the possible complications? Of course, this is an invasive procedure, and it might carry some risk for the patient. For example, exposure to ionized radiation And now the recent machines have reduced this risk very much. Risk of general anesthesia and allergic reactions, hypothermia, especially for small kids and small babies. But we avoid this by using warmer blankets. Aggravation of hypoxia, arrhythmias. You can imagine that we are using catheters and wires inside the heart. So the risk of arrhythmias is very high. Vascular injury, the sheaths introduced through the femoral artery and femoral veins might cause thrombosis, for example. Cardiac perforation, cardiac valve injury, blood loss that requires a transfusion, allergic reactions to the dyes or contrast agent that we use, renal insufficiency if we use so much contrast and not the patient is not sufficiently hydrated, CNS injury due to emboli or thrombosis, stroke, and or death. But of course, with proper planning, good training to all the staff member, the nurses, the technicians, the assistants, good preparation of the equipment, availability of all life support needed, these risks are very minimal. Our take-home message is that cardiac catheterization is an invasive procedure. Proper planning and preparation of the patient is mandatory. It's the cornerstone of your success in the cath lab. You cannot send the patient without good preparation, and you should have a clear plan what you are going to do in the cath lab. Intervention is a rapidly progressive field, and diagnostic cardiac cath, despite being still used, but its role is now taken over by other diagnostic procedures. This is our cath lab. We have two rooms in function now, and we are planning to get a new one soon, inshallah. Thank you so much for your attention, and I hope the lecture was useful. And of course, if you have any question, we are available in the cath lab every day. Thank you so much.